Hi everyone, welcome to day 2 of the 10 on 10 series for the upcoming NEET PG 2025 where we are going to discuss 10 questions for the next 10 days. The drill you know I hope by now, that is it's going to comprise of 5 mixed bag clinical MCQs and 5 mixed bag of image spotters which are important for the exam, and today we are on to day 2. In case you're new here and you've not seen day 1 video, then it is attached in the description, the link is there and you can view it at a convenient time. So let us start without any delay with the very first question, where we have a 35-year-old farmer who has come to the emergency department with fever, chills, headache and muscle aches. All of these symptoms have been there for the past 2 days, along with which there is mild vomiting and diarrhea. So investigations are being done, including culture testing done as well as serological investigations. And based on all of this, a photo has been given over here of a particular bacteria. If you look carefully, and even for those who've never studied bacteriology, you can easily make out that there is a spiral organism that is present, which clearly tells me it belongs to the spirochete family. Now, the spirochete family will have many bacteria, but the ones where the ends are going to be hooked is particularly Leptospira. In the rapid revision videos, I have taught you as a mnemonic that Leptospira sounds as Lapeta, who are spiral, so you will know it has those hooked ends, which I can see. And that's the clear-cut answer over here. But does it fit in with the history of farmer having these symptoms? Yes, we have changed the name of Leptospira with lots of R's because that will tell me about the life cycle of Leptospira bacteria. It is going to be caused because of RRR, that is when rat urine is going to go and contaminate or get mixed with rainy water. Now that rainy water which has rat urine is now going to come in contact with the rice field or the paddy field workers, because this is the crop which requires a lot of water. So that water which is now mixed with rat urine is going to come in contact with these farmers, and they will then contract the Leptospira bacteria. But what exactly does Leptospira cause? What is the name of this disease known as? It is referred to as the Weil's disease. And I noticed the 3 R's are done, that is rat urine with rainy water and rice field workers. But what is the last R standing for? That when you do a culture, you are going to get a Dinger's ring, and that ring stands for the last R, and that Dinger's ring is obtained on a media called the EMJH media. Before I move on to the next question, now they have also done in over here some serological testing, basically to know for antibodies. There are 3 serological testings which I taught you as the last question on day 1 in yesterday's class. That was cold agglutination test, standard agglutination test and microscopic agglutination test. You have to tell me which out of these 3 what did I teach you for Leptospira. That's your homework for the day, and I'm waiting for the answers in the comments. Now let's move on to question number 2, where we have a 30-year-old female who comes from Bihar to the OPD with complaints of fever for the last 2 days. The blood pressure is 130/90 approx, pulse rate of 78, and there is lymphangitis. Now when the blood investigation is done, there is a sheathed microfilaria, which anyway I knew from the options that I'm dealing with filariasis. But as soon as they say sheathed microfilaria, you are going to think of 3 things, that is LBW. LBW includes L for Loa Loa, B for Brugia malai, and W for Wuchereria bancrofti. These are the 3 sheathed filaria, and I can see all of them written over here. So I go for LBW. It is definitely not Onchocerca volvulus. Let me read further. They say there are no nuclei in the tail tip. That definitely now makes it Wuchereria bancrofti. So whenever I'm going to get sheathed filaria, the sheath is this orange color sheath that you can see around this filaria. So that is going to be one of these 3. Now how will I differentiate between them? I will look at, I have not shown you the entire microfilaria. I've only shown you the tail end, because you're going to focus on the tail and you will see whether it has nuclei or not. So let me start with the first one, that is Wuchereria bancrofti, and if I zoom in and see, there are no nuclei at the tail tip. The nuclei are ending over here, so there are no nuclei at the tail tip, which tells me in Wuchereria there are no nuclei, as if they have vanished like magic. There is magic, whoosh, they have vanished, so there are no nuclei. When I talk about Brugia malai, Brugia reminds me of bi, which will tell me that there are 2 nuclei present at the tail tip. Now when I talk about the third one, that is Loa Loa, it sounds like L for L, so there is going to be a line of nuclei. If you look carefully, continuous line of nuclei are seen right till the end. So that is how you differentiate between the 3 sheathed microfilaria. And now over here they said there is whoosh, that is no nuclei at the tail tip. I marked it as Wuchereria bancrofti. But how is the question clinically going to help me? Sometimes they don't give you the microscopic investigations, they give you clinical, and I've got you all the pictures in one place. Whenever they are talking about any kind of filaria, we all know the classical photo of elephantiasis, a swollen limb, and that is because of obstruction of lymphatics. Now that could be be a very basic question asked to you that why does elephantiasis occur? Because of lymphatic obstruction. The lymphatics get so much obstructed that ultimately the lymphatic channels might burst, and if the lymphatic channels burst, the lymph will start coming out into the urine. What is that known as? Chyluria. Chyle means lymph and urea means urine. How will the urine start looking like? If lymphatic fluid comes in the urine, it will start looking like milk, as you can see over here. So now when they give me this kind of a clinical and they say there are no nuclei at the tip, I will say, oh, that is a case of Wuchereria bancrofti. Let's look at the next one. There is another filaria which is known as Onchocerca. I hope you're not getting confused. This is not a part of LBW. So is this going to have a sheath? Not at all. This is unsheathed. But what do I see over here? It is causing something very, very important, that is known as leopard skin or dermatitis. If you look very carefully, the skin has become very, very black. You know how I've learned Onchocerca? Everything about it is black. This is usually seen in the black population. I can see that the patient is having black skin, which you've called as the leopard skin and dermatitis. And the vector for this is going to be black flies. So if they mention black population, black flies and black skin, they're talking about Onchocerca. But what does it cause in the eyes? Because that's another PYQ that you've been given in the exam. Onchocerca causes river blindness. I mean, everyone remembers river blindness, but what is river blindness? It is blindness, but look at the eye over here. It looks as if it is entirely covered by some sheath. That is referred to as sclerosing keratitis. That is river blindness. And if you focus on the word river has ivor, so the drug of choice for river blindness in pharmacology asked is also mentioned over here, that is ivermectin. That is about Onchocerca. Now moving on to the last one, that is known as Loa Loa. Loa Loa is also referred to as the African eyeworm, and I don't have to say anything beyond this because the eye and the worm both can be visualized. There is an eye over here and I can see the Loa Loa worm inside it. Remember, this is a part of LBW, so this definitely has a sheath. But apart from that, I can see that there is a swelling in the hands that has occurred over here, and this is referred to as the Calabar swelling. You know, this was once upon a time important in INI set, not asked much in NEET PG, but I feel it could be asked. So what is Calabar swelling? It is seen with Loa Loa, and it is a condition in which there is a hypersensitivity. I would call it a hypersensitivity reaction because of this Loa Loa parasite. Now there is a swelling and redness that you can see. So that is Calabar swelling that you have. These are all the clinical pictures with which question 2 is over here. Over it was simple lymphangitis with fever, no nuclei, whoosh, so Wuchereria bancrofti. Coming on to question 3 is a very simple one but made lengthy to waste your time. There's a 28-year-old individual presents to the clinic with persistent watery diarrhea, abdominal cramps and dehydration. So of course for a diarrhea you'll do a stool examination, but on stool examination there is no trophozoites. You could not see trophozoites. You know it is a parasitic infection, but you can't see trophozoites. What are you going to do? So now to identify, you are doing a string test. They are actually asking you what is the purpose and the procedure of the string test. If we start reading, is the string test done to diagnose liver flukes and to collect bile samples? Think of your answer first. Why do you do a string test? It is basically a test done for Giardia lamblia. Basically what you're doing, you're making the patient eat this capsule. The capsule is going to go all the way down to the duodenum, because from the duodenum you are going to catch Giardia lamblia. Giardia lamblia tends to sit in the duodenum. So why string? Because the capsule will go all the way down to the duodenum, but the string is going to remain over here. You will put a tape over here, and after some time you will pull the string out so that whatever contents you have got from the duodenum, now you can look at them under the microscope and you can see Giardia lamblia. So are you doing this for looking at the liver flukes or the trematodes? No. Next test, are you doing it for Helicobacter pylori? No. Then are you doing it for rectal region? Again, no. The correct answer is option D, that the string test is done for knowing small intestinal infections where you are looking at, for example, duodenal contents, and you are mostly doing it for Giardia lamblia. Now, this is a string test that we do for what? In the patient. We are sending a string in the patient. But there are two more string tests that you do in microbiology which are done in the microbio lab. One is done for the rice water stools, that is Vibrio cholera, and one is done for Klebsiella. Usually when they give you a question, it is to do with Klebsiella pneumoniae. So these are the two string tests which you are doing in a microbio lab on a culture or a plate, or basically some microbiological test for Vibrio cholera and for Klebsiella. But the string test which is done in patients, that is the string test which is done for Giardia lamblia. So with that, even question number 3 comes to an end, and let's move to question 4. What is the characteristic histopathology that you will find for Whipple's disease? I hope you've not forgotten that Whipple's disease is named so because it is caused by a gram-positive bacteria called Tropherema whipplei. So when this comes into the body, this is going to actually cause a condition known as malabsorption. The intestine cannot absorb much, and the classical histopathology is mentioned in option 4, that is pass-positive macrophages in the lamina propria. I'll show you this. I've got you a picture over here. Very clearly you can see that, okay, these are the intestinal villi. Yes, I'm telling you normal because nowadays a lot of normal photos are also asked. So these are the intestinal villi, which you can see makes it intestine. Then you can see these empty cells which are looking like goblets. So goblet cell makes it intestine. But now in the lamina propria, below the goblets, I can see cells. Usually, ma'am, when you draw cells, they are very pinkish. Here the cells are very whitish because these are referred to as the foam cells. What are the foam cells? They are nothing but macrophages that have eaten or engulfed Tropherema whipplei. See, it's a bacteria. What will your macrophages do? They are foodies. They are always hungry. They will go and eat the bacteria and hence they become foamy. If you want to prove that are these foam cells genuinely Tropherema whipplei, what is the special stain that you'll put? I will be putting pass, P for pink. Suddenly all those whitish cells have become pinkish in color because I have used a pass stain. So what cells am I viewing? I'm viewing the macrophages, and in which layer? Lamina propria. Every word is important. Pass positive macrophages in the lamina propria makes a diagnosis of Whipple's disease. Why did I tell you in so much of detail? Because whenever I will see foam cells on histopathology, my differential diagnosis will number 1 be Whipple's, but will also be TB. How can you forget TB in our country? Macrophages will want to eat TB also. So how will I differentiate whether it is Whipple's showing foam cells or TB eaten and showing foam cells? Because TB will obviously be positive for the famous acid fast or the Zn stain, and you're not going to mess up on that. I'm very confident. Coming back, I've got my answer, but when would you mark option A? I mean, I'm asking you other way around, that I've given you the answer. You tell me the clinical history. When will you see blunting and flattening of the villi? That is seen in a disease called as the celiac disease, the disease which is caused by gluten. So if I make you remember your normal intestine histology, the finger-like projections are referred to as villi, and these round structures are referred to as crypts. But when a person has celiac disease, basically when that person is eating gluten and he cannot absorb gluten, he cannot digest gluten, he starts making antibodies. Those antibodies are now going to go and damage the villi. So what is the first thing seen? See, all the villi have become flattened and blunted. So there is blunting of the villi, and because the villi have flattened, what is going to compensate? I can see the number of crypts have increased. So the next thing that we notice is crypt hyperplasia. That is what you see in the gluten disease, celiac disease, and together in medicine, this criteria for celiac disease is referred to as the Marsh criteria, another very important question in medicine. Question 4 is also done. Moving on to question 5, without which I think personally my revision for you would never be complete, is this question, where a 25-year-old woman has come for the gynec examination and a cervical pap smear is done. Although you don't expect a 25-year-old female to have this, but a biopsy has shown an invasive cancer. So of course this must be associated with the very famous virus called HPV. Right? Now they've asked you that what is the mechanism by which HPV is going to cause cancer in this patient, and the correct answer is the inactivation of the tumor suppressor proteins. Let me analyze this because I've got a photo over here. Firstly, what is this picture of a pap smear showing to us? This is the very famous coilocyte which you see with human papilloma virus. How do you describe a coilocyte? Number 1, you will look at the nucleus. The nucleus is looking very shriveled, just like a raisin. So that is referred to as a raisinoid nucleus, like kishmish, that's raisins. It's very shriveled and dried up like a raisin. And around the nucleus, I notice there is some whitening that is present. So around the nucleus, that is known as perinuclear halo. These two things together are referred to as a coilocyte, and they will just tell you HPV infection. They don't tell you that definitely patient has cancer. They will just tell you that some HPV infection has occurred in the patient. I hope you've not forgotten that HPV is going to be of two types. One is the low risk HPVs, which includes numbers 6 and 11. One is the high risk HPVs, which includes numbers 16 and 18. The low risk HPVs are going to cause warts, which you call as condyloma acuminatum in dermatology, and the high risk HPVs cause squamous cell carcinoma. And if you feel that's a very simple question, this was the recent INI set May 25 question that was asked, that which are the high risk HPVs that cause squamous cell carcinoma. Most commonly it is 16 and 18. Now I also have a set of questions which have been asked earlier. That's the entire structure of human papilloma virus given to you. We know it's a DNA virus, but what is every protein responsible for is a PYQ. Starting with the outermost, that is the L1 capsid. L1 is what is utilized for making a vaccine. So that's the PYQ. Vaccine preparation is done from L1. Who makes the coilocyte? The coilocyte that you just now studied is made by the E4 and E5 proteins, which I can mark over here. Finally, who causes cancers? It is the E6 and E7, which I will label now. These two are the ones which are responsible for causing cancers. How do they cause it? E6 is going to go and switch off the policeman, that is P53 gene. E7 will go and switch off the governor, that is going to be the RB gene. If you remember, P53 gene and RB gene are tumor suppressor genes. Indirectly, I'm saying that I'm inactivating the tumor suppressor genes, and that is why cancer is occurring. Go back to the question. Cancer is occurring because HPV is causing inactivation of the tumor suppressor genes, which to P53 and RB gene. How is it causing? E6 is going to go and suppress P53, E7 will go and suppress the RB gene, and that is why cancers occur. So all the questions regarding HPV come to an end for you over here. 5 questions are done. Let's move on to 5 spotters. The first one is a culture. I hope you could identify these tiny, tiny little fried eggs. As soon as I say fried egg colonies and very, very small, you think of the smallest bacteria that you know, Mycoplasma. Mycoplasma causes fried egg colonies. I mean, that is not the question that I expect. They will ask you, fried egg colonies are seen on which agar? They are seen on PPLO agar. And because you are saying that the Mycoplasma is the smallest colony, they will ask you that these fried eggs are also going to be very, very small. If you have to view them, you might have to add a stain on them, and that is known as the Dines stain. Please note, this is not Dines phenomena. That's your homework number 2 for the day. The first homework was that which agglutination test will you do for Leptospira? That you will let me know in the comments. And the second homework is that you will tell me that which is the bacteria which shows you Dines phenomena, because for Mycoplasma you have Dines stain. Moving on to the next one, question 7. There is a sign that is mentioned where you can see over here that there is a unilateral swelling of the eye, around the eye, orbital swelling, and this is the famous Romana's sign. So if you remember the story of Rome and the jackass life which I've taught you in the video lectures, you can answer this very easily. So Romana's sign is seen in a disease which is known as the Chagas disease. Chagas disease is caused by which organism? Trypanosoma cruzi. How can we get Trypanosoma cruzi? By which vector? It is the famous kissing bug, or known as the triatomine radiovid bug. And for the treatment, remember this was all about the jackass life where you are roaming in Rome and you are driving a Mercedes Benz. So what is the treatment? The treatment is going to be benzimidazole. Question 7 is also done. Moving on to spotter. Question 8. As soon as you see a rash which is looking as if the child has been slapped, so that is known as the famous slapped cheek appearance. Along with that, the same rash is present on the hands and the feet as if the child is wearing gloves and socks syndrome. This is the famous parvovirus B19. So it causes what? Number 1, slapped cheek appearance. Number 2, gloves and socks. But what can it go and cause to the bone marrow? In pathology, if you are asked, it makes the bone marrow shut down. So it causes aplastic crisis in the bone marrow. I hope you've not forgotten, parvovirus B19 is the smallest DNA or the smallest virus that we have, and it is the only single-stranded DNA virus that you have to know. So smallest and single-stranded, another 2 important PYQs. Moving on to question number 9, which is a dermatology favorite, where clinically you can notice over here there are umbilicated lesions. If you want to zoom in and view, there is a depression that you have in the center, and as soon as I show you an umbilicated lesion, you know you are dealing with molluscum contagiosum, which is a pox virus. So what would you see under the microscope? Under the microscope, there are these pinkish bodies that you see with molluscum contagiosum, which are known as the HP bodies or the Henderson-Patterson bodies. In dermatology, you are asked what is the special stain for Henderson-Patterson bodies. It is for HP bodies, it is the floxine tartarate stain. Remember, molluscum contagiosum is a pox virus. What is the shape of pox virus is a PYQ. Pox is a box. So it looks like a box or a brick, and it's a bhari wala box. Bhari wala box means that the DNA that is present inside it is going to look like a dumbbell. If you remember, in yesterday's session, I had taught you a dumbbell which was the asbestos body. That is also dumbbell shaped, and now I'm telling you that the DNA of the pox virus is also going to be dumbbell shaped. Moving on to the last image that we have for today is a peripheral smear examination, and you can see these red blood cells, but what's different about them? They are completely round and they don't have any pallor in the center. These are completely round, means these are spherocytes. If I ask you what is the most common cause of spherocytes, please don't say hereditary spherocytosis, because that is the second most common cause. The most common cause of spherocytes is autoimmune hemolytic anemia. So the first test that you will be doing for autoimmune hemolytic anemia will be the Coombs test. If it is not autoimmune hemolytic anemia, then you will think of hereditary spherocytosis. Remember, that is an autosomal dominant disorder. So you will always get father, mother, brother, some family history. And if it's not hereditary spherocytosis, then it can also be seen in G6PD deficiency anemia. So that's the order that you have to follow in the exam as soon as you see spherocytes. Of course, with that, we wrap up all the 10 questions that we had to for the day with 5 MCQs and 5 images. I hope you remember your 2 homeworks that you have to let me know in the comments. Number 1, which agglutination test for leptospira? And second, which is the bacteria which shows you Dine's phenomena? So do let me know in the comments. I have read all the homework answers that you gave me yesterday as well about papillary necrosis, and so many answers you knew, more than me also you knew causes, which is amazing. And this practice is entirely for you, because the more you type and write out means you will be able to retain it for a longer time. So I'm watching out for these 2 homeworks as well for today, and I'll be meeting you on day 3 with another set of 10 questions. Keep studying. All the very best.